Hi everyone, welcome to my theatre. Now that we have learnt about the visual field changes in glaucoma and the optic disc changes in glaucoma, we need to know perimetry. So what exactly is perimetry? Perimetry is a way to know about the visual field changes. The machines and the techniques and everything that we use to know the visual field change in a patient is perimetry. So this test is a subjective test, which means the patient tells us what the patient sees, and depending upon what the patient says, we appreciate the report. So this is one test in glaucoma which is subjective in nature, which means dependent on the patient's response. So this perimetry is to chart the visual field, which is a subjective test. Now, when we talk about the types of perimeter, there are broadly two kinds of perimetry. One is the static perimeters and one is the kinetic perimeters. The kinetic perimeters are the old perimeters, the static perimeters are the new perimeters. The kinetic perimeter means, as the name suggests, the perimeter moves, the machine moves. That's why it's known as a kinetic perimeter. And the static perimeter, as the name suggests, the machine doesn't move. In kinetic perimetry, there is movement of the machine, but the stimulus intensity stays the same. In static, there is no movement of the machine, but the stimulus intensity changes. And this kinetic perimetry is more useful in neurological disorders. The static perimetry is more useful in glaucoma. Now, what are the kinds of kinetic perimeter? Well, most of them are history, but the mystery of the history is important so that we can see what's the present and what's the future. So even though most of the perimeters are not used nowadays, still you get questions from them, and that's why you will have to know the names of those kinetic perimeters. So what are those kinetic perimeters? The first and the foremost kinetic perimetry method is a confrontation test, which is used even now, but not in ophthalmology. It is used more in neuro-ophthalmology and in medicine. The second kind of kinetic perimetry is a Goldman perimetry, which is a gold standard perimetry because it helps us to see the central as well as the peripheral visual field defects. But again, as I said, every name that we say is a history apart from the confrontation test. The third kind of perimeter is a Lister's perimeter, and this Lister's perimeter helps us to see the periphery. I'll show you the pictures of those perimeters and how they look, and briefly about how the tests are done. So the third kind of perimeter is the Lister's perimeter. What is the fourth kind of perimeter? The fourth kind of perimeter is a Jerem screen, which talks about the central as well as the peripheral, which talks about the central visual field defect. And the fifth kind of perimeter is an octopus. Okay, so these are the kinds of kinetic perimeter. Sorry. Now, what are the kind of static perimeters? The static perimeters, the first and the foremost, the most important kind of static perimeter is a Humphrey visual field. The second kind of static perimeter is a swap. The third kind of static perimeter is a FDT, that is frequency doubling perimetry. Okay. Okay, so now let's take some notes. Here, as I said, in kinetic perimetry, the stimulus moves. That's why we call it a kinetic perimetry. In static perimetry, there is no movement. In kinetic perimetry, the intensity stays the same. The intensity of the stimulus stays the same. But in static perimetry, the intensity of the stimulus changes. The kinetic perimetry is more useful in neurological disorders. And the static perimetry is more useful in glaucoma. Now, what are the examples of kinetic perimetry? The first one is your confrontation test. The second one is your, so what is another kinetic perimetry? Goldman kinetic perimetry. And when we talk about this Goldman kinetic perimetry, this is the gold standard and it tests both the center and the periphery. The third kind of kinetic perimetry is the listers. Sorry, listers, which test the periphery. The fourth kind is the Jerem tangent screen, which tests the center. And the fifth is the octopus. So these are the 5 kinds of kinetic perimeters. Now what are the kinds of static perimeters? The static perimeters are the first one, that is the Humphrey visual field. And this Humphrey visual field is the most important one, and this is the one which is used in every clinic wherever there is glaucoma practice. Now we have this short wavelength automated perimetry, SWAP, and this perimeter, well, in every perimeter that we have discussed, we have a white on white background, like there is a white background and there is a white stimulus, but this short wavelength automated perimetry has a yellow background with a blue stimulus. And the third one is a frequency doubling perimetry, FDT, which uses flicker stimulus. Okay, and as I said, all these perimeters, they are white on white, which means the surface on which the stimulus is given is white and the stimulus is also white, except the short wavelength automated perimetry, which has a yellow background and blue color stimulus is given, and the Jerem screen, which has a black background and white color stimulus is given. Apart from that, everything is a white on white perimetry. Now I'll just tell you, so the first, we will first discuss about the kinetic perimeters. Well, briefly, not important, but few points about each perimeter might be important. And here when we discuss about the kinetic perimeter, the first one is the confrontation test, and this is an important one. It is important for neurology, it is important for neuro-ophthalmology, it is important for medicine because it's a bedside test. It can be done in the clinic and it can also be done in the bedside to grossly evaluate the visual field of the patient, where the examiner and the patient, they sit at a distance of 1 meter and they face each other, and assuming that the examiner's visual field is normal, because if the examiner is problematic, then we can't test. So assuming that the examiner's visual field is normal, the examiner will close one eye and the patient in front will close the opposite eye, and then the examiner just at the center, which means between the patient and the examiner, just in the midway, the examiner will move an object from the periphery towards the center and will ask the patient to convey when the patient sees the object. And this should be same for the examiner and the patient. If the examiner is appreciating the object at this point, then the patient should also appreciate the object at this point, which means the examiner and the patient's visual field is same, which implies that the patient's visual field is normal. But if the examiner can see and yet the patient says, no, I can't see anything, it means we can suspect that there is some problem in the visual field of the patient. But as I said, here the greatest assumption is that the examiner's visual field is normal. And second thing is, we will always have to bring the pen in the center, exactly in between the patient and the examiner. Okay, so this is a very simple technique, a bedside technique, gives us some gross information which can be helpful for neurology and medicine. Now, the second, as I said, is a Goldman perimetry. This picture is important, which was one asked as an MCQ. So this is how the Goldman perimetry looks like. This is a gold standard kinetic perimeter which was used before, which tests the central as well as the peripheral visual field. Now the third kind of perimeter is a Lister's perimeter, which tests only the peripheral visual field, where the patient is asked to put the chin here and this will be rotated and an object will be brought from the periphery to the center, and in each field it will be checked how much the patient can see. This is how this Lister's perimetry is being done. And then the fourth kind is your Jerem tangent screen, And in Jerome tangent screen, the screen looks something like this. See, this is the screen, and at a 5-meter distance, the patient is asked to sit. 5 meters, just imagine, such a huge distance. It's at such a huge distance, the patient is asked to sit, and we will be showing some certain stimulus here in the screen, and we will be asked whether the patient can appreciate or not, and then we will create this map based on what the patient has seen, which basically tells us about the central visual field. And this is how the octopus works. Here in Humphrey the machine shows the dots, but here in octopus the operator constantly shows the dots and asks the patient to appreciate where the patient is seeing the dots. But most of these, like the Jerome tangent screen, the listers, the Goldman, they are not used these days. We use confrontation, but all the other things are not used nowadays. The most popular perimeter is your Humphrey visual field perimetry, because this is the one which is used in every glaucoma clinic today. And this is how the Humphrey field looks like. So here, this is the machine, this is the patient, this is the operator. Well, operator doesn't have much of an action apart from setting the routine demographic details and eye of the patient. After that, the operator doesn't have any role. The patient has to do everything, and the machine does everything. So here, after entering the demographic details and the eye and everything, the patient will be asked to sit. One eye of the patient is closed. Near correction, if the patient has, then the near correction of the patient will be given so that the patient can see the near. And then the patient is asked to fix at a central target. Why? In every perimeter, the patient will be asked to fix at a central target, because that is the definition of the visual field. We want to examine how much the patient sees when the patient is looking at the center. So here, the patient will be asked to look at the central target, and then the patient will click whenever the patient sees something. The moment you see, you click. The moment you see, you click. And when you keep clicking when you see, that will form a map, and printout of that map will tell us about what is the visual field of the patient. Okay, so this is how, and how does the report look like? This is how the report looks like. There is extensive, again, that's out of your syllabus. As undergraduates, that's out of your syllabus, but this is how the report looks like. And as I said, by looking at the blind spot, you will know which eye it is. Blind spot is always present temporally. So now, if this is present temporally, and we know that here I am the patient and the doctor, they have the same direction. So here I am the patient, I am the doctor, I am both. So this is temporal, means this is the right eye. So here this is the temporal, which means this is the right eye, and you can see that this is the right eye of the patient. So this is the blind spot, and blind spot is present temporally, which means this is the temporal side, and if this is the temporal side, means this is the right eye. So this is the right eye. And this also gives some information about how the test, whether the patient was fixating or not, how many fixation losses were there, how many times the patient has unnecessarily ticked, how many times the patient was supposed to click but hasn't clicked, how much time, for how much time the test was done. So a lot of information we get. The grayscale, what is the peripheral field, so a lot of information this gives, which altogether is a different topic, which is out of your syllabus as undergraduates, but you need to know that this is how the field looks like. Okay, and this is the glaucoma hemifield test, talks about the visual field index, mean deviation, pattern standard deviation, all this information this graph gives. Now finally, the short wavelength automated perimetry, which uses, which instead of a white on white, it uses, it has special significance in certain diseases, it is helpful. And so it uses, see, you can see that here instead of the screen being white, you see that the background is yellow, and in this yellow background, we kind of give a blue stimulus, okay, blue dots. We show blue dots in this yellow, and we ask the patient whether the patient is able to see or not. And the final one is the FDT, that is a frequency doubling perimetry, okay. So this one is a short wavelength automated perimeter, and this one is a frequency doubling perimeter. Okay. So with this, we have briefly covered about the perimeters, you need to first know what perimetry is. Then you need to know the concept of kinetic and the static perimetry. And then you need to know the names. As I said, history is mystery, yet it's important. So we need to know about the names of the perimeters, then the names of the kinetic perimeters, the names of the static perimeters, and how they function, a little bit about how they function, a little bit about how they look like, and finally we need to know that it is the Humphrey visual field which is currently in practice in every glaucoma clinic. So this is the brief concept on perimetry. I hope you enjoyed, because I have enjoyed it. I've actually enjoyed teaching you all. Thank you.